Hello everyone, welcome to part 2. We're going to go ahead and get started with that case study that we left off from part 1. If you went through, you should have highlighted some of the things that you found that were abnormal with the laboratory results. We saw it had a low hemoglobin, the leukocyte count was relatively low, had a low number of neutrophils, platelet count was a little bit low but not too severe. Stud rate was very elevated, it was 110, where normal is 10 to 20. And alkaline phosphatase was a little bit high, although that is not really something that we would find striking in a child of this age because usually children do have higher alkaline phosphatase ranges due to their growing bone structure. You'll see here too, I did not highlight them, but the ALT and AST are slightly elevated, but they're not markedly elevated. To me, it wouldn't be something that would cause them to think that there's a severe liver issue going on, for example. It is a little bit elevated, probably due to the amount of inflammation that's going on with the infections in her body, but it's definitely not so strikingly elevated that I highlighted it. So other things that you should have read in the case study were the laboratory investigations revealed decreased hemoglobin, raised stud rate, neutropenia, and lymphocytosis. The blood culture showed Staph aureus, which is very important to make note of. And on peripheral blood smear, there was giant granules present in the neutrophils. That should have led you in one direction. Eosinophils and granulocytes. Bone marrow biopsy revealed myeloperoxidase positive inclusions in the neutrophils, which would be those giant granules again, and its precursors, as well as in monocytes and lymphocytes. Hair microscopy revealed multiple small pigmented granules in the hair shafts as well. So as you went through, the big find in this was the giant granules. So it's likely to be Shediac-Higashi. Now, what they would probably do from here is go on and do some more genetics type testing to see if that may be the case, to definitely diagnose her as that. But everything in this would lead you to believe that she has Shediac-Higashi. All right, let's move on to the new information. All right, we're going to move on to what would have been Chapter 4 in your immunology textbook. The lymphocytes and plasma cells. We left off talking about some of the phagocytes and things. So this will be the other portion of cells, the lymphocytes and plasma cells, and how they are involved in your immune system. We have some primary lymphoid tissue in mammals. This includes the bone marrow and the fetal liver, along with the thymus. That is where the undifferentiated lymphocyte cells would more likely to be found. Now, once they become more differentiated and they have a job, they move on to the secondary lymphoid tissue, which we find the lymph nodes, the spleen, gut, in your bronchus, skin, thoracic duct, and blood. So many different areas we find our lymphoid tissue. Starting with the T lymphocytes, we find that they have the cluster designation antigens that promote cell-to-cell interactions and adhesions. One of the important things that we talk about a lot are the CD4, CD8 markers, the single, as I call them, the single-digit markers. The T cells we find are of the markers that are less than 10. So we find the CD4 markers, CD8 markers on the T helper cells and the T suppressor cells, which I'll get to in a little bit. They are involved in the transduction of signals that lead to the lymphocyte activation as well. We have the subsets you have to be familiar with those T cells. First, we have the T helper cells. Those are the effectors, and they regulate the production of antibodies. I have memorized these as though T4 and HELP, 4 is 4, and then HELP has the 4 letters. HELP is the 4 letters, so that's easy to memorize. Then we have the T cytotoxic and the T suppressor cells. Well, the cytotoxic cells are just as they sound. They're toxic and they destroy cells with viruses. But the suppressor cells downregulate the T and B cells. They do as they sound. They suppress the function of the immunity that's going on with those T cells and B cells. If you had extreme production of immunoglobulin over and over and over and over again, there would be way too much production and it would cause other issues. The suppressor cells are there to stop that so it doesn't get out of control. Now, the T8 cells are the suppressor. Okay? So that has, I know it only has 9 letters in it, but it looks more like it's got 8 letters in it than the helper does. So that's how I memorize which one's T4 and which one's T8. The ratio of T helper to T suppressor is 2 to 1, which makes sense. You want more help than you do suppression. And we'll get into this in part 3 as well, but those HIV patients, the problem with them is that HIV virus attacks those T helper cells. So once those T helper cells get squashed down to a point where there's more suppressors than there are helpers from the HIV destruction, we end up flip-flopping that ratio around. So those HIV patients watch that ratio very carefully, because once it starts to flip-flop, that's when they move into the acquired immunodeficiency syndrome away from the HIV. So helper goes down, suppressor goes up. As you can imagine, that is not an ideal state to be in. Okay, so we do have antigen processing and presentation to T cells. Those are different ways that the antigens are presented to those T cells so that they can function in a way to fight off that infection. There's the endogenous pathway, which involves the CD8 markers, and the exogenous pathway, which involves the CD4 marker cells. And they just have different ways of presenting that antigen. A couple other types we have here is the natural killer and the K-type cells. The natural killer cells are able to destroy those target cells through a non-phagocytic mechanism called cytotoxic reaction. It is MHC unrestricted cytolysis. They just go in and bam, kill off the foreign body. The K-type is a little bit different. Those are mononuclear cells that can kill target cells, but they have to be sensitized with an antibody first. Okay? If they don't have an antibody on them, they can't kill them. Natural killer, they don't care. Either way, they can destroy it. The last one here are the B lymphocytes. B lymphocytes, their important claim to fame is they secrete the antibodies. They also just demonstrate surface immunoglobulin, and they can differentiate into plasma cells. One B cell differentiating into plasma cells, which are the ones that look like the fried eggs that you've learned about in hematology, they secrete the antibodies. So they have a very, very important role. They also participate in an amnestic response, which is that secondary response, as memory cells. They have the following cell surface markers. They have surface immunoglobulin, FC, C3, C3b, and other surface antigens as well. All right, let's move on to everybody's favorite part of immunology. Let's get through this complement monster. Now, when it comes to complement, I know you may struggle a little bit with memorizing some of this, and I'm going to point out the highlights of it. Now, when you're studying for your boards, it's not in your best interest to memorize this whole entire thing from the beginning to the end, and every single little part and piece, and every single thing that it does, and be able to draw it out, because your boards are multiple choice. Okay? So if you have a question on your board, it's probably going to be a larger case study, and they're going to give you a complement level that may be increased or decreased, and they'll probably give you the reference range, and you're going to have to figure out, is that normal or abnormal, or what type of situation might be going on. So while you should be very familiar with the parts of this and how it works, being able to draw it out with perfection by the time you take your boards is probably not the best use of brain space. But let's get through this guy, and I'll point out the really important parts of what you really need to know. First of all, what is complement? Complement is synthesized in the liver. There's 18 heat labile, which means they're destroyed in the heat, proteins. They're inactive when they're in circulation. They need to become activated by previous complement components and the interactions that are taking place. We have three different ways that complement can be activated. We've got the classical pathway, the mannose binding lectin pathway, and the alternate pathway. Now, each one starts off in a different way. The classical pathway requires C1q binding to an antibody that has been bound to a cell, okay? And it could be like a bacteria or something like that. The mannose binding lectin binds to the oligosaccharides on virally infected cells in most cases. And the alternate pathway does not require an antibody. That just has it just comes in contact with the polysaccharides on the surface of the bacteria, and that causes spontaneous breakdown of C3 into C3b and C3a. Let's start off with the classical pathway. You should be familiar with the fact that it's not in order. It goes C1, C4, C2, C3, C5, 6, 7, 8, 9. So 4 comes after 1, and then we have 2 and 3. Well, which complement protein is in the largest concentration? This is one that you need to be familiar with. It is C3. C3 is, let's back up a little bit. Let's start off at the beginning. I'm sorry, I started following my directions on the left-hand side. But if you go back, you can see, and I'm up here. I'll circle this for you quick so you can see where I am. C1R, C1Q, and C1S binds to the immunoglobulin to cause the cleavage of C1, or causes activate C1. Activated C1 causes the split of C4 into C4b and C4a. From there, we get down to the C4b2 and end up with the C3 convertase C4b2a. The C4b2a, you do have to be familiar with that being the C3 convertase of this. From there, the C3 convertase causes the breakdown of C3 to C3a and C3b, and those have important roles too, and we'll get to that in a minute. From there, we end up with the C5 convertase, which is very important to know. That is C4b2a3 little b. So that causes the breakdown of C5 into C5a and C5b. Here we have the beginning of the membrane attack complex. C6 comes in, C7, C8, and multiple C9s come in to disrupt the cell membrane. Okay, so that is your classical pathway in a nutshell. Now let's go back and answer these questions on the left-hand side. The one that is in the largest amount in the blood is C3. The major component is C3, and it's the major residual split of C3b. C3b plays a very important role in opsonization, which peppers those cells and makes them, what I say, ultra tasty. Okay. C3a, as you can see with that as well, is the other residual split of that, causes the release of histamines from basal cells, so that'll play a role in some of that inflammation as well. Where is complement made? All complement proteins are made in the liver. People with liver disease, things like that, are going to have a hard time making complement proteins. So if you see a case study on your board and the liver enzymes are elevated, you see complement is decreased, they might have some coag tests that are increased because they don't have enough coag proteins either. Anything that involves the production of proteins are usually made in the liver. So it can always lead you back to some type of liver disease if there is a decrease in the amount of complement that's there. What are the three stages? The three stages on here involve recognition, activation, and the membrane attack complex. As a review, up on top, which component binds immunoglobulin? That would be our C1q, specifically. And what starts the pathway? That would be C3. Sorry, I'm on the wrong one. That's alternate. The activated C1 would start the whole pathway. All right, what is cleaved as a result of the activation of the classical pathway? Well, that is C4. C4 also acts as a very important viral neutralizer. So he is one of the two tests that when I worked in chemistry in the laboratory, we always did C3 and C4 tests. Those seemed to be the two complement proteins that the physicians were most interested in. So he is as a viral neutralizer, and then C3 is the largest amount. Okay, so those two seem to be very important when it comes to physicians ordering tests. All right, what component activates C4 and C2? That would be C1s. And C3 convertase, we showed on here, C4b2a. And C5 convertase, down here, is C4b2a3 little b. All right, what is the recognition unit? The recognition unit is the C1q up above. I have him up here. Can I erase all my circles here? What is the C3 activation unit in the classical pathway? That's C4b-C2a. What initiates the MAC complex? That would be C5. It's also important to know that C5a has potent chemotactic activity. So he really likes to draw in more attention to get more help with more complement proteins. Which proteins are involved in the MAC attack, as we call it? C5, 6, 7, 8, and 9. And the final step in complement leads to cell wall disruption and a hole in that cell membrane. The last question, at which stage does complement reach its full amplitude? That would be C3. All right, so as painful as that was, I kind of went through and highlighted those questions that you needed to know. Feel free to stop right here and go back, because you are watching an archive, and watch this slide again if you feel that you want to get through and take some more notes if I went through it a little bit too quickly. All right, so we're going to move on to the alternate pathway. Which component starts the alternate pathway? Well, this is the spontaneous breakdown of C3 when it comes in contact with a cell surface of a bacteria or foreign organism. C3b can be inactivated by the sialic acid on certain mammalian cell surfaces. So if we have mammalian cells, so that would inactivate that C3b. So we wouldn't want C3b to destroy our cells. What cleaves and activates factor B in the alternate pathway of complement? Well, that would be factor D. So that's the big difference between the alternate and classical pathways. We've got factor B and factor D. The enzyme that is bound to convertase only in the alternate pathway to stabilize it is propyridine. Okay, he's specific to the alternate pathway. And it activates C3 as well. Our last one here is the mannose-binding lectin pathway. He uses MASP1 and MASP2, which are very similar to C1R and C1S, and they cleave the C4 and the C2. All right, last questions with complement here. What causes elevated levels of complement and what causes decreased levels of complement? The elevated levels of complement can be found in somebody with glomerulonephritis, which is an inflammation of the kidney, inflammatory conditions, traumas, and myocardial infarctions or heart attacks. We find the complement levels to be decreased if it has been recently activated, recently being consumed, or if you have a genetic defect. And just another review, we talked about these a little bit in the first section, but what is interferon that attacks virally infected cells? Tumor necrosis factor is involved in killing off gram-negative bacilli, and interleukins are the communication factors that work between different leukocytes. All right, let's move on to some diseases. These are always really fun to learn about. This is where things get more exciting for me in immunology. All right, so your body has different ways of responding to different types of diseases. So the ones we're going to go over in this section include bacteria, parasites, and fungal diseases. So bacteria, the main defense mechanisms for bacteria include phagocytosis and lysozymes. Unfortunately, it can sometimes escape phagocytosis by having a capsule or some type of exotoxin that can fight off our immune system. Parasites, those may avoid being phagocytized because of mobility, so those are a little bit more challenging. But we do find that immunoglobulins, complement, and eosinophils do play a large role in the fighting off of the parasites. What about fungal diseases? These can be challenging, and these are all what I call the osises. We can have a superficial, which is on your skin, or a systemic infection where it travels through your body. If somebody is immunosuppressed, these things can become opportunistic very quickly, meaning they can take over your body. Some of these, for example, cause problems in AIDS patients because their immune system has become so suppressed. So they would be considered immunosuppressed. Therefore, these can become very opportunistic places for these fungus to grow and cause problems in the human being. So what's so tough about these fungal diseases? Well, they do have an anti-phagocytic capsule, which makes it very challenging for the immune system to try and attack. It resists macrophages, it destroys phagocytes, so it makes it very easy to become very ill with these. First one is histoplasmosis. This is can cause pulmonary problems. It comes from birds. It can cause a fever. We find it in a culture. The next one, aspergillosis. This one we see a little bit more in the laboratory, sometimes in the elderly and immunocompromised as well. It can cause an allergic reaction because some people are allergic to mold. This is your typical mold that you may see on your loaf of bread. It can be invasive and disseminating. It's usually secondary to another disease where we find this sometimes. Elderly patients may come in and they have influenza. We then find that aspergillosis can grow than in their lungs once they're kind of it's like kicking them while they're down, so they have the flu and then they get an aspergillosis infection. We usually find it by the microscope, and or we can do some type of immunodiffusion or IgE testing for that. Coccidiomycosis, also called desert fever or San Joaquin fever or valley fever. We inhale this through dust. Usually can be cutaneous or disseminated, so you can have it on your skin or it can go through your bloodstream. And it's usually diagnosed by hypersensitivity testing. Blastomycosis is one that's a little more popular in my area. In Green Bay, Wisconsin, we usually get people that travel up to Upper Michigan for their cottages and things, and they'll come down with a nice case of this. This one looks like a large snowman. He's my second trip here. And he's kind of fun to find, as unfortunate as it is for the patient. He does look like two big bubbles attached to each other. Look like they can cause tumors in the skin, lesions in the lungs, and bones sometimes. Patients that have blasto, if it's not treated very quickly, it can kill you very quickly. Cryptococcus, this one we find from pigeons. This is from inhaling the yeast from that. Sporotrichosis is my bottom picture. This one can get in your lymph nodes, and that's pretty much how this has traveled through this person. It can be disseminated or respiratory, usually where you got it. Sometimes they call this rose bearer's disease. So let's say this person scratched past some thorny rose bushes, and you develop this chancre type thing at the site of inoculation, and it will then disseminate from there. So what about viruses? Well, how do viruses replicate? They replicate inside of cells. So you can see the scary looking guy here on the right hand side. This would be a virus. Now, is this exactly what it looks like? No, but it's a good depiction of exactly how this works. So what he does is he goes around, he plops himself with his little legs on top of a cell. He then uses his little spore down, or his little poker here, sits down, and he injects his viral material from his capsid through the sheath down into the cell. And our bodies, it's our cells. So our body does not recognize that as being a foreign cell while all of this viral replication is taking place inside of that cell. So your immune system's floating past, going to everything's fine, but meanwhile, in that cell, there's all this viral replication taking place. And after all that replication takes place, a viral burst happens. The cell bursts open and releases many baby viruses to go and infect other cells. This is why it's so challenging to fight off viruses. We do have some ways to fight these off. Interferon does help us out. Sometimes antibodies do, and macrophages occasionally can help with some of those virally infected cells. What about the difference between rickettsial and mycoplasmal diseases? Well, rickettsial diseases, they are obligatory intracellular organisms with cell walls that are very close to a virus, and that's what you would see on this right-hand side. Mycoplasmal diseases are without a cell wall but are capable of extracellular replication, and they're very close to a bacteria. The next type of virus would be herpes virus. These are large enveloped DNA viruses that replicate within the cell's nucleus as well. We usually find two different types, type 1 and type 2, where type 1 is typically found more in the lip, as you can see on the top picture. Type 2 would be found more in a genital. Now, they are both found in both places. Next one, varicella-zoster virus. That would be chickenpox, which you see a cute little guy down here on the right-hand side. Chickenpox is one that you want to get when you're a child. You don't want to have this if you're immunocompromised or elderly. It can become very painful. It can also resurface as shingles, which is horrendously painful, and can get itself in your nervous system, and it's just extreme pain. There's another herpes virus called human herpes type 6, which can cause roseola or measles. So how do we detect for some of these immune responses? Well, we usually look for an IgM, which means you're physically ill. If you have IgG, it means that you may have had the disease, or you've had the immunization to it, and you've now developed an immune response to it. There's also some other things they can do to check for viruses called the torch profile. And the torch profile includes the toxoplasma, other viruses, rubella, CMV, and herpes. You do need to know that. In other cases, if somebody has come down with an infection, the doctor may draw an acute versus a convalescent specimen. The acute specimen would be drawn right after the beginning of illness, and a convalescent specimen would be drawn a couple of weeks later to see if they're starting to develop the antibodies to fight that off. Okay, moving on to vaccines. Vaccines are very important to reduce the amount of vaccine-preventable diseases. No vaccine is totally effective or 100% safe. You'll come across all different mixes. There are all different sorts of opinions on this. There's some people that absolutely refuse to vaccinate their kids, and there's some people, and I have a friend who lives out in Maryland, who is so gung-ho on vaccines and gets so upset when people refuse to vaccinate their children that he'll go on a rant on it for hours if you let him. So there's definitely varying opinions on this, but definitely they're not all 100% safe, and they're not all 100% effective. So you think what you want, but that's the true story. They can be divided into a couple different types. We can have a live or attenuated vaccine. So that means it's not going to really make you that sick, but you could, have a few side effects from it. It's a live virus, so your body actually makes antibodies to that. Another one can be an inactivated toxoid, if you think of your tetanus shots. And there's also non-replicating vaccines, that they just inject you with a virus that cannot replicate. In order for a vaccine to be used, it has to provide active immunity with very minimal side effects, according to the FDA. It has to be immunogenic enough to produce a strong and measurable immune response, and it has to have a stable shelf life, with the potency remaining at a proper level. After somebody has a vaccine, sometimes a titer might be done. If you've had your hepatitis B shots while at Rasmussen, which you should have, when you get your first job, they might draw a hepatitis B titer on you to make sure that you're immune. If you are not immune, they may give you a booster shot to try and boost that immunity. A titer, which I talked about a little bit in the last section, is the reciprocal of the highest dilution at which an antibody can still be detected. So a person with a titer of 1 to 2, I think I have this backwards, is more immune than someone with a titer of 1 to 4. This is backwards. If you have the higher the titer, the more immune you are. So I'm going to go ahead and cross that off. The higher the titer, the more immune you are. Just go with that. Crossing those off. So again, acute and convalescent specimens. Acute drawn during the illness, and convalescent 2 weeks later. All right, this is really tiny. Hopefully you guys can read this on your slide, but I wanted to fit a lot of stuff on one slide. Let's talk about strep infections for a minute. You guys have not only learned about this in immunology, but you also get another dose of it in microbiology, and then we're going to hit you with it again in capstone during both. Strep infections are very common. I can't think of anybody who has never had strep throat. All 3 of my kids have had strep throat. Very, very common. Also, I have unfortunately know someone whose son has the rheumatic fever that can come from this. So he had strep when he was little. Parents didn't know about it, never got it treated, and it went and caused heart problems. Now he has to see a cardiologist and get a shot of penicillin in his butt every single month till he's 16. The poor kid is 9. So I'm always very, very diligent when it comes to my kids being sick with a fever and having a sore throat or a scratchy voice. I always get a strep test done because that is one of the few times I'll beg for antibiotics. All right, so what is strep? Gram-positive cocci. Strep pyogenes is the group A strep. There are different antigens and things on them. If it has an M protein, which makes it virulent. If it does not have that M protein, it won't be. Has a couple extracellular products, and what do they do? Well, the streptolysin O creates a hole in the red cell membrane. Streptolysin S is what causes this beta hemolytic reaction that you see on your blood agar plates. It also produces a few other things, such as hyaluronidase, which is a spreading factor, DNA aces A, B, C, and D, which degrade DNA, streptokinase, which dissolves clots, and there's an erythrogenic toxin, which can cause scarlet fever and a rash. Usually you find this in the respiratory tract, and it's spread droplets, milk, and food. The symptoms are upper respiratory, usually that sore throat. You can get impetigo, which is on your skin, and a cellulitis, which would be like a big skin infection. Your skin gets really hot to the touch, inflamed, and scarlet fever if it's left untreated. Other complications, acute rheumatic fever, which is what that little 9-year-old Alex said I know, and it's very unfortunate for him. His mom said he can't even get him in the parking lot of the pediatrician because he knows he's getting that painful shot. And it can also cause glomerulonephritis. Those immune complexes and things can block up that kidney and cause inflammation in the kidney. It produces several antibodies called ASO, anti-streptolysin O. So that is a test that you may or may not have done in your lab. We can diagnose it by doing cultures in ASO titer to look for those antibodies. And we can do acute and convalescent serum 3 weeks apart to see if they are in fact improving. There's also a streptococcal toxic shock syndrome. That is more found when it ends up disseminated into a like a septicemia type of situation, and that would be treated with can be treated with penicillin as well. So what about Group B strep? This is why I have the picture of this cute little baby down here. Group B strep, all moms are tested for that, usually between 30 and 35 weeks. I don't remember. I was tested for all 3 of my children. And it can cause meningitis in babies. Now, it can harbor itself in the mom, and it doesn't cause us any problems at all, but it can make the baby very sick. Usually they will do that testing on moms just before birth, and I know with me I was positive with my first child, but I was negative with my second too. I don't know. So I was treated with IV antibiotics while I was in labor with my children. All right, the next one I have here is syphilis. Syphilis is caused by Treponema pallidum spirochete. I have a cute little picture of a spirochete over here. It's usually treated with penicillin. It's usually a venereal disease, and it can be transmitted to the fetus via the placenta. And there's a couple different things you need to know about syphilis. There's primary syphilis, which is the first picture. You see a chancre on the genitalia. Usually that's in 10 to 90 days or so. The secondary syphilis is after 2 to 8 weeks. That primary chancre goes away, so everyone's like, oh, no big deal. Then you end up getting a headache, sore throat. So you feel like you got the flu. Then you get these skin lesions on your hands, and I'm assuming these people think, oh, I hurt myself. Like if, you just think, oh, it's just a sore, it'll go away. Well, the sad thing is that it does go away. So then you wait 3 to 10 years later, before you know it, it's in your central nervous system, and it's causing you to go a little bit loopy. So tertiary syphilis is 3 to 10 years down the line. The other type would be congenital syphilis, where it has been transmitted by the placenta. In order to test for this, usually we do a rapid plasma reagen, an RPR test, a flocculation type test, to test for the proteins of syphilis. If this is positive, we don't immediately call the patient and tell them that they have syphilis. We do a confirmatory test, which it would be called the FTA-ABS. That is a fluorescent antibodies you can see in the bottom here, this little black circle. It would cause spirochetes to actually glow. Now, VDRL is a non-treponemal flocculation test done on spinal fluid, and the RPR would be done on serum. Those are important to know. Next one, tick-borne diseases. We got Lyme's disease and Borrelia burgdorferi, and burgdorferi to me sounds like Ferrari, so I've got a lime green Ferrari up here to help you with that. So the spirochete Borrelia burgdorferi. This is transmitted by ixoid ticks, and it can create an erythema migrans rash. I have a story about this too. My husband's uncle has a cottage up in where is it? Crivets, Wisconsin, which is an hour north or so of Green Bay. And his neighbor had to sell his house or his cottage up next to him because he would go hunting all the time and he got bit by a tick. And this the long-term side effects are almost arthritic. His joints are so painful and I think they have scar tissue and stuff in him now from the healing of this. He couldn't work anymore, so he had to go on disability because it got so bad. And he had to sell his cottage because he couldn't go hunting anymore. So originally you get this erythema migrans rash, and it should be treated right away. It's relatively easy to treat with antibiotics and such. But the first stage, within 4 weeks, you get this rash. And I would imagine on dogs, this is impossible to see, so you got to make sure you keep ticks away from your dogs because ticks love to crawl in their hair. It's really easy for a dog to pick up ticks running through the woods too. Another thing is think of these really hairy guys. Okay, so I'm thinking some really, really, really hairy people. And how are they going to see this rash through all that? So that might be a common problem as well. I don't know. So they get this rash and the flu-like symptoms. Stage 2 can, maybe, who knows, a few weeks later, can hit your nervous system, your eyes, and your skin, and your heart. So you start to have more symptoms. After weeks to a couple of years later, it turns into that arthritis. You got neurological complications, difficulty walking even sometimes. So with this, we can do a culture and immunoassay to find this. Hopefully it's found early enough that it can be treated. And the prevention would be do a tick check and tuck your pants in your socks when you're going through the woods. Sorry, this is really close to home because if we live, especially with you guys too, if you are in North Dakota, Minnesota, or Wisconsin, there's going to be ticks there. All right. Next one, ehrlichiosis. The etiology is called ehrlichia. We find fever, chills, headache, and skin rash. The diagnosis is based on these WBC inclusions, and we treat it with doxycycline. You can see the inclusions in these cells down here. Now, some people oftentimes get that mixed up with babesia. Now, how do I memorize the difference between babesia and ehrlichiosis? Which one's in red cells, which one's in white cells? Well, I got a stupid way to help you memorize this. Ehrlichiosis is found in white cells. White cells are bigger and easier to lick. Okay, so if you had to lick a cell, a WBC would be easier to lick than a red blood cell would be. Okay, just safe. So ehrlichiosis is in the white cells. Babesia is in the red cells. Okay, so this one is actually transmitted by the I. scapularis tick. We find it sometimes in splenectomized patients and sometimes immunocompromised patients. You can even get it from a blood transfusion. Usually incubation takes 7 to 21 days. You get a fever, hemolytic anemia, fatigue. To diagnose this, and you can see, I know you guys have seen this in hematology as well, we find an increased retic due to the hemolytic component of the disease. So your bone marrow is trying to make more cells to make up for those. An increased LDH, bilirubin and haptoglobin. Intraerythrocytic organisms. That's what I just circled down here. It kind of has that little X-shaped pattern. And we could do the Fields test on thick blood smears, which is what you see down below. We can treat that with clindamycin and oral quinine as well. Okay, last slide. Toxoplasmosis. This is usually found in humans and animals and is caused by Toxoplasma gondii. This epidemiology is usually the oocysts in the feces of house cats. And even when I had my babies, they would give you a little handout and it would say things you shouldn't do, things you shouldn't eat. One of the things was do not change the litter box. Well, I never had cats, so it didn't matter. But even think about it. If you have kitty litter, which is dry and kind of sandy and dusty, so you have cat feces in there, right? It's getting all dried out. And it's getting kind of powdery. When you pour that kitty litter into the garbage and it creates all that dust and you breathe that in, I would imagine that's a pretty easy way to get yourself some toxoplasmosis. Ick. It is transmitted through the placenta, which is why it is can be such a problem with those pregnant women. Most of us would be able to fight off this infection relatively easily, but the pregnant woman, it's with the baby, it can be such a big issue. If you do get the acquired infection, if you are somewhat compromised, it can be asymptomatic, but it can resemble mono, and you can get encephalitis in your brain, probably pretty rare. If it's congenital, it causes central nervous system issues in the baby, and the baby can be blind. Some of the immunological manifestations we find in IgM and IgG, if they have a current infection or if they're immune to it, the IgG might come into play. We find lots of variant lymphs. And to diagnose it, they used to do something called a monocyte cell culture. They don't do that so much anymore. More often, we'd find the indirect fluorescence or an ELISA type of method for this. And these cute little guys, they look like little crescents here with a little nucleus in the middle. Those are your toxoplasma organisms. All right, so we're at the end of part 2. Please read the case study number 2 and answer the questions at the end. We'll review them in the next segment. So go ahead and take a good half hour or so and see what you figure out, and I will see you in a little while.